perfect. So my name's Patrick, as Amanda's just told me. Yeah, so Patrick Holmes, I'm a GP in Darlington and CCG lead for Tees Valley Diabetes. That's me.
Yeah. Amar?
Yeah, cool. So I'm a consultant diabetologist in the West Midlands and do random various things in diabetes across whatever I do.
Kevin?
Hi everybody, Kevin Fernando. I'm a GP partner at North Berwick Health Centre, just east of Edinburgh, and I'm also Scottish lead of the Primary Care Diabetes Society.
And Amrit.
Hi there, I'm Amrit, GP based in North Central London, specialist interest in diabetes, and I'm currently in my car parked up alongside the A23, so hence the background.
If you go past him, you need to beep your horn so we can hear.
Good to be here.
Sorry. Just while people are joining in on the live feed on Facebook, I'm just going to ask you some random questions just while we're waiting for people to join. So, as we've just had the American Diabetes Association conference, we're going to talk about that a bit later. But to start with, I'm going to ask you an icebreaker question. So, what is your favourite American state and why? Kevin?
Right. So I would probably have to go for Louisiana because New Orleans was the first time I'd been to Louisiana. Was, to be honest, was New Orleans, the ADA Congress a number of years ago, where I first met Amrit actually, and it just jumped to my immediate favorite state. Not because of Amrit, I should point out, and but mainly because the architecture, the cuisine. I mean, the temperature was quite humid, and that legendary Bourbon Street, of course, in New Orleans as well. But I towards the end of the day, I got a little chance to explore. I did one of those little swamp trips towards the end, so it was good fun. So Louisiana for me.
Amar.
So I'm thinking actually. I already said that. There's two that come out to me. One is Illinois because of Chicago, and I love Chicago. But actually, probably as a state, I'd probably say Massachusetts because of Boston. And the reason why, again, it's linked. Well, firstly, I have family there, so it's always it's always been great to kind of go down there and see them. But actually, similar to Kevin, my first ADA was in Boston, and I'm not a massive seafood person. If there's a menu, I'll go for meat or vegetables rather than seafood. But the seafood in Boston is amazing, and that's the first time in my life that I actually went for the seafood first time with everything. So I'm a big foodie, and so that's why it appealed to my stomach. So that's why I say Massachusetts and specifically Boston.
Lovely. Tamsin, have you got a favourite state?
Yeah, my favourite would be Georgia because one of my best friends went out there to live, and unfortunately, due to everything, I've only seen her a few times since she left. So yeah, Georgia would be mine.
Beth?
I think of all the places I've been to in America, quite a few. I think I like Washington DC, which I know is a little bit controversial. It's not a proper state, but that's probably the most beautiful city I've been to in America. So yeah, I'd go for Washington DC.
Patrick, what's yours?
So mine's California, the land of the fruits and nuts. And it's not. I don't like it because of the fruits or the nuts. But
wine.
But no, and really, it's a big state. Is California? So it's San Francisco. I love San Francisco. I've been fortunate to go to the ADA, and again, it was my first ADA, but 3 times I've been to San Francisco. So and it's over the years, and it's I love it. So and it's not just because you can smoke weed without being sort of locked up. It's because it's just a great place. It's a bit like being in Disneyland. You go, so you often stay in the center when you go there for the conference, but you can go out to Fisherman's Wharf and you go on the cable cars, and it's a bit like going on a fairground ride because it's up and down. So I love that. So and then you eat, and then you can get a bit drunk, and then come back on the cable car back. So yeah, perfect.
Childhood.
Amanda, do you have any GMC representatives on your Facebook account?
Hope not. Amrit, what's your favourite state?
So I'm going to be a bit of a copycat. My favourite state is California as well. You're never far from the sea, the beaches, all the mountains. It's got amazing weather. One of my favorite ADA conferences has been San Diego. It's just such a chilled out city. Very close to the Mexican border as well, so it's got a bit of Mexican influence there with the food. And yeah, that's where Top Gun was filmed as well. So there's lots of Top Gun references around the place. But yeah, California, definitely. And for all the reasons that Patrick mentioned as well.
Mine's Florida, because I've never been to anywhere else in America. But maybe after this we might get some invites to ADA next year. You never know.
It's in where is it again next year? It's
in your favorite state.
Back in New Orleans.
It's in Kevin's state.
Hey. So you need to get us an invite, Kevin. We'll do webinars.
Also known as the drunken state.
They're not great at inviting nurses.
Yeah, no, it's a pity.
Yeah,
there's definitely a not a parity there, which is it's an absolute shame. So I think obviously you've done great work as the forum. So hopefully, as a collective, you can get a group invitation.
Yeah,
very much. Like the congresses in the UK, they take a very multidisciplinary team approach. So I think it's absolutely right that the pharma companies in the UK should take a cross-section of the diabetes HCPs and not just mainly doctors.
Yeah, we're doing a follow-up to this on Tuesday with pharmacists and nurses.
Okay.
And we were only able to find one nurse that had been invited to the ADA out of our whole forum of 1,800 people. So
I've been quite because I sometimes support that, and I think Amanda, I remember you. Do you remember with ESD? I think we managed to get some.
Yeah.
I think ESD I find is a lot easier, but I'm not sure ADA always seems to be the one that's.
Yeah, we've all been to EASD, haven't we? I've been a couple of times to EASD. I think the same as Amanda, but it's just the ADA just seems to be a bit out of our reach.
Yeah,
rely on you guys tweeting and doing your videos and stuff for us to catch up on the gossip.
That's been really helpful for us to listen in on. So what we've come here today for is for you to tell us all about what you learned at the ADA. So who wants to go first and tell us their take-home message from ADA?
Well, I suppose my take-home message is things are not slowing down. Despite the obvious challenges of the pandemic, it continues to be a very tough time. Infection rates are rising. That pace, that evolution of cardiometabolic renal research hasn't slowed down at all, has it? I mean, look, Patrick's nodding away there as well. I mean, there was some really breaking news, some significant practice-changing research published that's really going to have an impact in making our lives a wee bit easier as HCPs, but ultimately to really help improve the lives of our patients with diabetes. So that's what I was delighted to see, to be honest. Just despite the pandemic, this last 18 months, we've got some fantastic research that's really going to make a difference to patients' lives. And where do you start? Well, I'll maybe hand over to someone else, but just very quickly, the SGLT2 inhibitors, they revisited the sotagliflozin trials, SCORED and SOLOIST. And these have been published already, but really reiterated the benefits of the class, and also as a nice nod to what we all heard a couple of days ago. Really, sort of when they revisited the sotagliflozin studies, really highlighted there are significant renal benefits, of course, but also potentially heart failure benefits in preserved ejection fraction, and that, of course, was highlighted with the top line from the Emperor Preserve study just a few days ago, which does tell us empagliflozin did indeed improve outcomes, hospitalization and mortality for people with preserved ejection fraction heart failure. So fantastic news. Of course, a lot of unanswered questions till we hear what Emperor preserved, the defined detail at ESC, but very exciting, wasn't it, Patrick?
Yeah. I would agree. I mean, that if you get a chance, if anybody can nick probably Kevin's login for the ADA but if you can watch, I mean, there was a great session by, and I always Muthu Vanganathan, is that So I apologize for getting his name wrong. I continue to get his name wrong. You would think I'd get it right after a number of attempts I've had. But anyway, but yeah, so there's a great one. And I think he just builds up the whole story about how complicated HFpEF is, you know, heart failure with preserved ejection fraction. But there was this promise that it came from those sotagliflozin in trials. So that was great. But for me, I think it was more as you say, it's the pace is moving ahead. And for me, it was the ADA this year was about incretins. So there was these gut hormones. And I think going back to, the tirzepatide stuff, I think, is fascinating. So this is this GIP, GLP-1 dual agonist.
Can you just tell us what GIP stands for those that don't know?
Oh, Christ, it's that Anyway, I tweeted it because I can't hold that. It's a bit like Muthu Vanganathan's naming. But anyway, it's a gut hormone.
Gustatory inhibitory peptide, yeah.
Hey.
These clever people who can actually remember things, and not wing it all the time. But so that was great because just going back to Amanda, it was mentioned that you were at and I think Beth was there. Well, Beth definitely was there in the EASD. So that's when we saw the first phase 2 data from that, and I can remember going, "Wow, look at that weight loss!" But now we're getting much more level of detail. So that looks amazing, and it's also really fascinating about what the contribution the GIP does add to it. So there's still a lot we don't know. And then with all these clinical trials, there was this sort of, because you'd think it'd all be pretty straightforward. This looks to be more effective probably than any other incretin-based treatment we've currently got. But yet there was in one of the trials there was an excess of deaths across each of the subgroups. So who took the tirzepatide versus semaglutide. So again, there's which doesn't make much sense, but it's one of those things I love, which is these unanswered questions, which ultimately over time we'll find out if they were just a spurious thing. I'm old enough to remember somebody once thought DPP-4 inhibitors would reduce stroke. So and clearly they don't. It's just research, which I love.
Was it done in COVID times? Could the excess deaths have been COVID related, or?
But it's a randomized controlled trial. So in theory, if it was COVID, and that's what they said, that half the deaths were COVID related. But since we're going to have COVID for the rest of our lives, probably at some shape or form, it's that's rather important. If somehow this molecule I personally think it's just one off finding in one study, because it was only they've got data from 4 similar sized studies, and it was just in that one study they saw it. But there's an ongoing cardiovascular outcome trial, which in a couple of years' time or 3 years' time will probably give us the definitive answer. But yeah, it's
the analogy here, isn't it, Patrick, is this lower limb amputation issue with canagliflozin, because I've been asked a lot about that recently, because pretty much all the data subsequently has not highlighted that again. So I appreciate it's not quite ADA, but I'd be interested on your take, all of you, because I'm actually a lot more relaxed now about the whole lower limb amputation situation in SGLT2 inhibitor use, because as I said, it's not being replicated in they've looked at it, of course, in DAPA-HF, Emperor reduced, all these other SGLT2 studies. So what Amar, what's your take on that? As I said, I used to say no SGLT2 use in anyone with either established or at risk of peripheral vascular disease or active or past diabetic foot disease. But to be honest, pardon the pun, I've taken my foot right off the pedal and boom. And I'm much more relaxed now about use. And certainly that's advice I've been given out locally to colleagues who've been out. Do you think that's reasonable, or do you think I'm being too gung-ho?
So firstly, I bet you were waiting to use that pun. Secondly, so I think it's about that at that point risk assessment. I think for SGLT2 use in those who've got peripheral vascular disease is a balance, because that 1% HbA1c will improve those and reduce the risk of complications. But if they've got active vascular disease which is causing problems, obviously no. But in the group who've kind of had previous old amputations for whatever reason, or that who we've got good, reasonable blood flow and whose H1C is high, there's some arguments for it. And if you can justify it in the patient, as long as you involve the patient, I don't see any reason it's not an absolute contraindication, as we say, but it's something that you just want to be aware of and make sure you've counseled them for as well.
So how about a patient with heart failure and diabetic foot disease? What would you do there?
So what's the state of that diabetic foot disease? Because that's the key thing. It depends on how significant it is my honest answer. I mean, you could argue, yes, if you improve the heart failure, that 28-day reduction in hospitalization, blah, blah, and all that stuff, benefit is obviously there. But then, you can go into hospital less and be less short of breath, but then you might have a toe knee's coming off or a foot knee's coming off. That's not my decision to make, is it? It's the person's to make. So everyone will have a different perception of what's important to them. And who knows, if you get an infection and it tracks up all the way and have to lose a whole foot or have to use crutches, that's something different, isn't it? That's just as bad as not being able to breathe and walk far as well, they could argue. So I think I'm wary of those with active foot disease. In those who've got active kind of ulceration, those who've got old healing ulceration, then you could argue, is there actually some benefit? And I think everyone's got a different kind of risk assessment as a clinician, but also as a patient. So it just depends where it matches and if there's nothing else. And with GLP-1s that we have nowadays, that's always something that I would consider. The heart failure, I think that's an interesting one. That's the only time where I would think about it, but I'd have to make sure that it was the right decision.
Sorry, I digress, but it's something I've been asked loads recently, actually. So that's.
Should we go to Amrit now? And is there anything that stuck out for you at ADA?
A couple of things. I think there was obviously the COVID theme that ran through the Congress. The impact of COVID-19 on patients living with diabetes. We had the DARE-19 trial, obviously, of dapagliflozin being tested to see whether that had an impact on improving COVID-19 outcomes. We didn't see that, but although there was some, and I know Kevin looked into this and commented on this on our GoggleDocs platforms, it gave some reassurance, at least, of using SGLT2 inhibitors during the pandemic and whatnot. But I suppose, so that was one theme, but really for me, the biggest thing was the incretins. So jumping on the bandwagon with Patrick there, I think the main things we saw were obviously the high dose semaglutide, but really for me, and the use of high dose semaglutide, so Sustain Forte, the use of semaglutide for obesity management, so that's the STEP program, and then also obviously the Surpass program, so tirzepatide. And it just has a feel that it's kind of similar to how we were thinking about the SGLT2 inhibitors a few years ago. Lots of brilliant results, great A1C reduction, great weight loss being seen. Which one do we use? And I think that's what we're now going to start seeing over the coming months and years, how we're going to interpret all the different trial data, and in clinical practice, which molecule do we actually use for which patients? And I think that's what's going to be really interesting. As we did for a while with the SGLT2 inhibitors, we're often getting asked the question of which SGLT2 inhibitor should we use for which patient. I think we'll have a similar situation with the GLP-1s and GIP combination molecules. So that's what stuck out for me, really.
Thank you.
So talking on SGLT2, obviously this week we saw Boehringer announce some quite exciting data about EMPA and HFpEF, so being able potentially to use that in HFpEF treatment. So did you guys see any of this or have anything?
Yeah. So this has been we briefly mentioned it. I mean, HFrEF, the bulk of the evidence we have to date is for HFrEF, heart failure with reduced ejection fraction, so roughly below 35%. And SGLT2 inhibitors have robustly demonstrated significant reductions. And it's interesting, isn't it, Patrick? Across the board, it's about a 30% relative risk reduction, all the studies have shown. But up till now, we failed to demonstrate any benefits in HFpEF. And that's partly because of study design, tend to recruit the lower ejection fraction patients. We had one study called Paragon, which looked at Entresto, sacubitril valsartan, which had some soft HFpEF benefits, nothing compelling. That said, the FDA has given it a nod for treatment of certain patients with HFpEF. And then a good old-fashioned drug, spironolactone, also given a slight nod, sorry, not a nod for use of HFpEF, but again, based on limited evidence. So that's why this recent announcement from Boehringer has been fantastic, because it's the first high-quality, dedicated HFpEF trial that is positive, and again, for an SGLT2 inhibitor. The problem with HFpEF, they're a really heterogeneous group of individuals. HFpEF is really driven, HFrEF, reduced ejection fraction, is really driven by ischemic heart disease, really, isn't it? A pump failure. Whereas HFpEF is really driven by comorbidities. So HFpEF is often the common form of heart failure we see in people living with diabetes, hypertension, and COPD and other comorbid. And that's why it's notoriously been very difficult to treat, just in a nutshell. So really exciting times. We've had no real robust trials demonstrating benefits in HFpEF up till empagliflozin. So again, great time for patients because like any sort of heart failure, as Amar's already alluded to, very debilitating, significant impact on quality and quantity of life. So great news, Patrick.
Yeah. No. I mean, I think I would agree with everything you said, and I think, and as you said, that because there are other things, there's multiple things driving that HFpEF. I mean, it's it's always been seen as a more challenging condition to treat. Whereas HFrEF, the origin of it is very similar, but the best. I mean, we've known for quite some time people with reported heart failure, right back from the EMPA-REG. There was evidence of benefits, but the numbers were small. It wasn't predefined. So, it was, it's as bad as our computer records. When it says heart failure, it's not always that accurate. So we got the best heads up that this was likely to work when we saw the data by what's his name? I've forgotten his first name now. But anyway, Deepak. Deepak. So Deepak. So, and he with this meta-analysis of all the sotagliflozin outcome trials, which Kevin alluded to, the sort of SCORED and SOLOIST, and that it showed that relative benefit, about 30%, was across the board. It didn't matter if you got a reduced ejection fraction or a relatively normal ejection fraction. So in people with a diagnosis of heart failure. But one of the challenges when it comes to a clinical trial is with HFrEF, the majority, most people die from cardiovascular disease, whereas when in HFpEF, things like cancer or sudden death or other causes, because often older and frailer, is greater. So the likelihood of trying, you've got less things to benefit to in a clinical trial. But the Emperor Preserve, they sort of expanded the numbers just to make sure that it was a big enough trial. Going back to what Amrit said about dapagliflozin and dapagliflozin in hospitalized people with type 2 diabetes, with COVID, that had both type 2 diabetes and didn't, they excluded type 1 in that in DARE-19, but that was probably too small. So they showed a 20% benefit, but it wasn't statistically significant. But it does. Whereas I think with Emperor Preserve, they threw enough money at it and got enough patients to get it over the line. So yeah,
I was just going to say, in terms of the heart failure data that's emerging and very positive data, if we take a step back though, we're still not that great, particularly in primary care, diagnosing heart failure. And I think as with all of these benefits that we're seeing, if we're not identifying the patients in the first instance having a diagnosis of heart failure, then the benefits are not going to be realized. So I think, if anything, I hope that from the emergence of all this positive trial data, that we actually start looking at the actual screening of patients with symptoms and signs of heart failure, and then actually utilizing the medication. So I think that's something that may come out of all of this through some, local educational work and whatnot. So I'm looking forward to that as well, because we're clearly underdiagnosing at the moment.
I would also say it's also prevention is better than cure, isn't it? So rather than getting them when they're diagnosed, It's also about risk factor management and the 3 treatment targets which are always there. Get those right, you reduce a lot of HFpEF because you're reducing cardiovascular burden, and that's the point of it. So regardless of SGLT inhibitors, use insulin, use GLP-1s. Sorry, throat's gone. using any medication to bring the blood sugars down and treat those risk factors, and you'll see improvements. Just because these trials are so short, you won't see that. So if you're looking at long-term benefits, you manage people appropriately, intensively earlier, then you'll see these benefits and all these complications down the line. We know that from before, from decades ago.
Tamsin, did you have a question? I think there was something came up. Oh, you're on mute.
I know. Yeah. So I think it was briefly mentioned about the DAPA trial in the COVID and the respiratory patients, and obviously not seeing a huge sort of benefit for those patients necessarily, but not seeing necessarily them getting worse or getting DKA. So obviously last year we were very much saying all these medications need to be stopped, people shouldn't be taking them. Is that trial big enough? Does it have enough data to give us an idea whether we should be changing our minds?
So, I mean, others will come in on this, but it was about 1,200 patients. As I said, there was a 20% reduction, and there is some data which is not actually presented at the ADA, but there was some evidence of benefit, particularly in people with CKD and heart failure more than the general group. So I think what it tells us is actually we need to personalize our care. And I think, and we need to make a judgment. So, I mean, Kevin often he hates the term sick day rules. They should be guidance. And I think we should personalize that. If you've got someone with heart, and it's one thing I would say, these patients were, closely monitored in hospital, and they weren't the sickest patients. I mean, these were hospitalized patients, but they were ventilated. They weren't critically ill. But it left me thinking this was an underpowered study. And particularly if you'd focused at those people and it was just 30 days. So we know you get heart failure benefit quite quickly, and you can reduce a kidney injury, but 30 days is still rather short. So it left me thinking that it was fabulous that someone did that trial, and actually you want a bigger study, as I say, in particular groups which we know are probably most likely to benefit from SGLT2 inhibitors, and it should be making us think we shouldn't be just automatically stopping it.
Yeah, absolutely. I would agree with Patrick, and I know you had a field day with that acronym DARE, didn't you, Patrick? And some of the stuff you were tweeting. So I think it has to be personalized. I think it is an underpowered study, so I don't think we should be making any sweeping changes on the basis of that. But it was a reassuring study. Really reaffirmed the safety profile of SGLT2 inhibitors, really for a good number of our patients living with diabetes. But, as Patrick has also alluded to, I think there are still some scenarios where we might consider stopping SGLT2 inhibitors during an acute illness to prevent things like euglycemic DKA. So, as Patrick said, I don't like rules. I just think that's too prescriptive. I think guidance helps us, hopefully prompts us to individualize the sick day guidance to that person sat in front of us living with or indeed without diabetes. Because to be honest, we're seeing the same situation with ACE inhibitors and ARBs. Just about 12, 18 months ago, we had some renal association guidance published actually telling us even in acute heart failure or decompensated heart failure with renal dysfunction, we shouldn't be suddenly stopping ACE inhibitors or RAS inhibitors because they do have prognostic benefits even in the acute scenario. So again, a great example of where we should individualize sick day guidance. So it's good, great study, and I think a bold study, but I certainly wouldn't be making any sweeping changes to my practice just on the back of that.
Yeah, it's a fine balance, really, isn't it? Because we're balancing the benefits of certain medications, for example, SGLT2 inhibitors, versus any potential risk in an individual situation. And I think we've also got to be alert to the fact that, discontinuing medications when a patient is in hospital, for example, or acutely unwell, will that medication then be restarted when appropriate? Or are we going to is there going to be a delay before restarting that medication? And we know that, for example, with COVID outcomes, the impact of uncontrolled A1C, etc., and the impact that that has on COVID complications. So it's an individual thing, but also a fine balance that we've got to consider there.
We've had a question come in, so I'm going to hand over to Beth so she can read that one out for you guys.
Yes, moving away from SGLT2, going back to the GLP-1, GIP kind of treatments. Everyone is, well, this person specifically was saying that we're seeing investigational drug put next to it everywhere on Twitter or any tweets that you guys have done or around social media and things. So does that mean it's not likely to become a treatment, or is that just being used because it's in trials, or what are we thinking?
Exactly the last one. Yeah. I mean, it was me who did that. It's just because in the past we've got our fingers burnt when we talk about drugs which aren't licensed yet.
Yeah.
We get people then suddenly tell us off. And it's like, well, you know, I mean, quite clearly we're talking about clinical trial. So it was just there are a few idiots out there. So it was really just to spell out that you can't prescribe that now. So that was all. So investigational drug. But I mean, I'd be surprised if it's not licensed in a few years.
Actually, it's due for a Q1 2022 release. So we're going to be seeing it very, very soon. It's going to be in the same device as Trulicity.
Oh, great! So yeah,
wow.
It's a Lilly product, and it's going to be in the same device as Trulicity, which, you know, is one of the ones I use on my Formulary. Very simple to use device. So yeah, Q1 2022, we'll see.
That's going to be a real game changer, isn't it? Because sometimes people will choose their medication on the device, even if the results.
I was laughing at
the results and the device in one. Ooh.
Yeah. No, I was laughing at game changer. I was wondering how long it would take for someone to say game changer. And
actually a shot. Do we have to have a shot now?
Yeah.
Bingo.
I thought it would.
What else is on the bingo?
Bingo load,
so we've got paradigm shift. We've got a game changer. What else do we have?
Gina, that's always
3-point mace.
Yeah. Amar did the 3 treatment targets. I think that was
in terms of investigational medications, Amar, I know you were quite excited by the Amplitude O trial results and F-peglinotide. Is it worth mentioning?
Great name.
How'd you say that again, Amrit? How'd you say that again?
I'm just going to go for F-peglinotide. That's what I'm going for.
Aren't they? I think the more that comes out, we're getting more and more crazy names.
Yeah, I guess excited is the wrong word. I don't know. It's F-peglinotide, but
F-peglinotide. There we go.
F-peglinotide.
A bit like what was it? The Vertis CV trial a few years ago. I like the trials that frustrate you a bit or kind of throw a bit of span in the works or stuff. So F-peglinotide is a molecule that's, I think, with Hanmi, a Korean company, but was previously with Sanofi, but they relinquished the license or the support with it. And so it's kind of a bit like albiglutide a few years ago. These molecules that are being, they spend lots of money, industry, on building these molecules. And then to take to the next stage, they need some further support. So some molecules get it, some don't. So F-peglinotide is one of them that was getting the investment. So it had this cardiovascular outcome trial with a view to marketing it. But then now it's kind of stuck because there's nobody promoting that drug. But F-peglinotide is a once-weekly GLP-1 analog, and it's rather than like dulaglutide and Trulicity and semaglutide, it's kind of the traditional old school GLP-1, the lixisenatide and exenatide, the exendin-based ones. And so the trials in the cardiovascular outcome trial, the GLP-1s, if you see, all the benefits from GLP-1s from the cardiovascular side have been seen with the human ones, so the dulaglutide, semaglutide, but not with these earlier ones. So this is the first trial that kind of showed actually there's benefit with this F-peglinotide. So they found cardiovascular benefits, so reduced this 3-point MACE and all these other kind of cardiovascular benefits, as well as some renal benefits potentially, and even a sign that there's heart failure benefit, which is all the heart failure. It's not quite first, it was there with albiglutide, but there was some evidence that's showing maybe you might get some heart failure benefit, which has traditionally been the SGLT2 realm. So I like this trial because it added a bit kind of complexity, saying kind of, well, actually, it's not all clear-cut human versus extended. Now it's actually, is it just the longer-acting GLP-1s are better? It also said, well, what do we do now? We can't do anything. We've got this molecule that has benefit, but it can't do much. It's just really nice urine ACR reductions and renal potential benefits as well. And also there's a group of the population, about 15% of the people had SGLT2s as well. And always the big question everyone asks is, okay, GLP-1s show benefit, SGLT2s show benefit, let's whack them together, what will that show? And no one ever gives you a clear answer. The trials have looked at glycemic benefits and weight lowering, which shows benefit, but nothing on cardiovascular side. And they did a little analysis because they could, and they said, well, it doesn't matter whether you're on SGLT2 or not, this epiglycine showed benefit in these cardiovascular outcomes. So you could argue perhaps with both, there might be added benefit. Now, there's not enough power or not enough people for them to kind of fully say that. So even if they do analyze that group, I don't think we'll get anything conclusive. But again, it added a little bit more to what we're looking at with the CV outcome trial. So that's why I liked it, even though there's not much we can do with it at this point.
Oh, I think Beth's got a question, is she, or is it Tamsin?
Patrick's going to tell us about how drugs get named, aren't you?
yeah. So it's something I always wondered how these daft generic names, which you think, well, but they're named actually. It's two women in the States in Chicago. It's part of the FDA. So all these drugs. So tirzepatide, before it was called tirzepatide, was called LY with a long number name. So, but yeah, it's just two people. So so there are some rules about how they do it, but which is beyond me. But it's just two people sat in an office naming all these things. That's what it is.
That's so funny. That's almost like the little elves that Santa has. You just imagine them sat there.
Yeah, it's the Wizard of Oz, isn't it? You're behind the curtain. There's just two normal people. But that's
I wonder how you apply for that job. That would be pretty cool. See it in the Echo. Drug namer.
Maybe they don't like doctors though, because some of the names. I mean, it has to be said. If you try to spell it, so if you're anything like me who's a bit dyslexic, it's a bit of a nightmare. So anyway.
Right. We've had a question on Facebook.
Okay, that one. And then
I'm going to read it out because I was going to type it into the chat box. But hey, right. Would a GLP-1 be beneficial for a patient who had lost 2 stone, keeping it off, BMI is 26, HbA1c had risen to 90. He's been on DAPA for the past 2 years. He should possibly be on insulin, but he drives for a living. He's relatively young, 54. Very long question. I think we need probably a little bit more history there. So the chap is lost 2 stone. His BMI is 26. Would a GLP-1 still be suitable for that gentleman? He's on an SGLT2 inhibitor. His HbA1c is 90. Or do you think he's probably better off on insulin, but he drives for a living and he's only 54?
Who wants to take that one?
Amrit, go for it.
I'd say yes. I think we'd need more information, obviously, in that for that case to individualize, obviously, the management. But that was one of the beauties of some of the data that we saw in ADA this year. That actually, the GLP-1s, the indication initially for glucose lowering, and as we saw with the higher doses, as across the board, it's very difficult to compare the different trials that we saw, but generally, as the dose of the GLP-1 molecules were increased, perhaps we started to see a bit of a plateau in terms of HbA1c control, and then it was more the weight loss. So initially, as we build up the doses, for example, of semaglutide from the 0.25 to 0.5 to 1 milligram, that's where we really start seeing the HbA1c reduction. So I think perhaps the question is, a person asking it, maybe, I'm not sure, is concerned about the weight and whether are we okay to initiate a GLP-1 with that weight loss already? Obviously, with more information about the case, we'd want to make sure that there are no other causes for weight loss. I think safety first. But if we can be reassured of that, then yes, absolutely. And we know that we're not only getting A1C reduction, but potentially some more weight loss, getting this patient to a BMI of less than 25. Depending on ethnicity, we may want that BMI to get a little bit lower, in fact. And then also the cardiovascular benefits of having a GLP-1 receptor agonist. We know with dulaglutide, for example, we get protection from a primary prevention perspective. So even if the patient doesn't have cardiovascular disease established, so I would say yes, but with an asterisk. And yeah, I don't know if the guys have anything else to add to that.
I was just going to say it's probably because the NICE guidelines are still so outdated with their BMI for GLP-1s that people are reluctant to use them in people with a lower BMI.
Yeah, I mean, in terms of glucose lowering, they work the same at people with a BMI of 26 in terms of HbA1c reduction. You don't get as much weight loss typically in that group because there's less excess weight to be lost, but you do get the HbA1c reduction. Certainly, I mean, so there's plenty of studies which show that. And I mean, I was involved in the SURE study, so plug a study I was involved with as a principal investigator. And that, in the real world, you got that HbA1c reduction across the board, but it was the weight was different depending on the BMI. But there was, just going back to the ADA, there was a study which you can't really make too firm conclusions, mainly because they're still adjudicating some of the cases, but there was the GRADE study, which was sort of meant to ask the question, what next after metformin? And they didn't have an SGLT2 inhibitor or pioglitazone in the arms, but they had SU, basal insulin, a GLP-1, which was liraglutide, and a DPP-4 inhibitor. And there was, from that, there was, in terms of macrovascular disease, perhaps the first evidence of proper primary prevention going on in people who'd only had diabetes for about 4 years. So, we've seen a little bit in Rewind using gelaglutide, Trulicity, but they, quite honestly, they were quite high risk individuals, that had stress testing and things like that positive. So these people had angina, even though they hadn't had an event, but they were called primary prevention. So there was there's some evidence of that. So I think, bearing in mind, if he's in his 50s and this chap's, assuming he's not developing type 1, that would be one of my anxieties, but assuming that's you can exclude that and other causes that Amrit alludes to. Yeah, I mean, we shouldn't be just looking at the glucose. We should be looking at the person as a whole, and probably his trajectory is to go on and develop heart disease or kidney disease. And we've got agents now which, over and above the glucose lowering, seem to have a beneficial effect in those areas. So yeah, we should be using them. And sod the NICE guidance, they're just to guide us, not tramlines. We should treat our patients first, not some pharmacist stuck in an office who never has to deal with a family of a bereaved patient. We've got to do our best.
I would say also, even if he doesn't want to take insulin, then you've got to manage him and his sort of concerns, and say, well, if that's the case, I'd rather have something that's going to work and produce HbA1c than not be on anything. And so, from that perspective, and even I say, if insulin's a barrier, then use GLP-1 as well. Hopefully, that weight there, but they do give you license. So yeah, I agree with it.
I agree with everyone as well. I mean, he's a young chap. He's a good 10 years younger than Patrick. He needs to. We need to make sure we minimize his future risk of micro and macrovascular disease. So I'd be going early in with atherosclerotic benefits of the GLP-1. And on top of all the great incretin research we've just been chatting about from ADA, I absolutely, I think that would be a very appropriate treatment choice, even in the context of his 2 kilograms, 2 stones weight loss. Yeah.
So we have a question on the. Sorry, Amrit.
No, I was just going to add in, well, now we also have an oral formulation of a GLP-1 receptor agonist. So that's also another thing. If the patient has resistance or hesitance to using an injectable, for whatever that reason might be, we also have the oral option as well. So just something to consider there.
Brilliant. We have a question on the F word, which I'm going to pass over to Beth, because she might be able to pronounce it. It's not what you think.
Yeah, I can pronounce that one okay. I can't pronounce it. So moving away maybe from heart failure and stuff and going towards the kidney kind of side of things, we saw a lot of information and tweets and things about I'll
pick up this because I've written a wee bit about this. I know the guys could all I think the F word you're referring to is finerenone, I think.
I'll be the one.
Yeah, that's the one.
Finerenone, which actually just yesterday got a nod from the FDA to be, it's licensed now to use for diabetic kidney disease. Kerendia is the brand name, Kerendia.
Yeah, which is much easier to say.
So not yet in the UK. So in a nutshell, finerenone, unfortunately, is yet another new molecule we need to know about, or know a little bit about. So we're all familiar with spironolactone, aren't we? Spironolactone is something that's been in our armamentarium for a while. It's my go-to fourth line drug for resistant hypertension, for example. So spironolactone is a mineraloreceptor antagonist, a steroidal type drug. So that's why you get side effects such as gynecomastia with spironolactone, whereas finerenone is a non-steroidal MRA, mineraloreceptor antagonist. So it doesn't have the same sort of side effects as spironolactone. It still does cause some hyperkalemia, hypotassium like spironolactone, but otherwise has quite a different actually side effect profile, clinical profile to spironolactone. And what, in a nutshell, what's been discovered in a couple of studies, Fidelio and Figaro, is that finerenone significantly reduces the progression of diabetic kidney disease and also reduces major adverse cardiovascular events, including some heart failure benefits too. So this is specifically for diabetic kidney disease, okay? Whereas SGLT2 inhibitors, as we all know, have also been demonstrated to have renal benefits in a population without diabetes. So, but finerenone is specifically diabetic kidney disease. So where are we in the UK at the moment? It's currently undergoing a nice TA technology appraisal. So we may see it on our shows later on in the years, later on in the year. But I suppose that the question is, where does it fit into our treatment pathways? And this is perhaps where I'd like to hear the other guys' opinions, because, you know, if we have someone with diabetic kidney disease, optimal dose ACE inhibitor, ARB, we'll be adding in an SGLT2 as well shortly. So Patrick, where do you see finerenone playing a role there? You know, it's like the 5 pillars of heart failure. We now have 3 pillars of kidney disease, or diabetic kidney disease anyway.
Yeah, it's difficult, isn't it? Because as you said, and the way these drugs seem to work, and we've got the Fidelio study, so that came out and that showed, that was primarily a kidney study, so that showed benefits in kidney, but as a secondary outcome there was benefits in terms of cardiovascular, which is what you'd want in this sort of high risk group, people with kidney disease. It's a bit like foot problems. You know, if they don't die of the foot problem on the whole, they don't die of the kidney problem on the whole. It's cardiovascular disease which takes these people away in the majority. So what you want is something that will reduce cardiovascular disease. And there's Figaro, which is coming out. That's which is going to be there. Figaro. Yeah, anyway, so that's coming out soon. It might be even, I don't know if Kevin knows when that comes out, or if Amar.
Well, actually, yeah, we had a top line from Figaro, which is positive, ESC, but then to confuse matters, we have the Fidelity coming, which is a combination of both the Figaro, because they're essentially the same study. So they're going to join them together to further increase the power and give us more details. So that's all ESC. Yeah.
ESC, yeah, exactly. There'll be lots on finerenone and ESC. The other
We
thing
have another question from Facebook, because we're going to be running out of time soon. So Tamsin, did you want to ask the question from Facebook?
Yeah. Do you think that oral semaglutide will have the same cardiovascular benefits as the injectable form?
Amrit, go for it.
You're on mute.
Schoolboy error.
That's the quote of 2020.
Yeah. There's a reason why I was on mute, because I didn't want to commit. But I think it will. It's the molecule that I'm thinking about. That the molecule is the same as essentially the same as the injectable. And I'm hopeful that it is. I'm looking at it right now in the patients that I'm initiating with one eye on that cardiovascular benefit. So yeah, but I suppose time will tell. I don't know if we've got any other opinions and thoughts about why it wouldn't. I'm trying to think why perhaps it wouldn't show cardiovascular benefit, and I can't think of any other anything to say it wouldn't. I don't know what the guys think.
Only reason I could think would be if because this is a trial, it would be, but if it's not taken correctly, or if it's not concordance with it. But I agree with you, Aaron. I think it will show.
Yeah, I mean, the reason it didn't show, because it's already gone through a cardiovascular outcome trial, which was Pioneer 6, and that was the shortest of all outcomes trials. Only very small, short follow-up. These drugs, GLP-1, you know, aren't like SGLT2 inhibitors, which offload the heart and have direct sort of hemodynamic effects on the kidney. So they work really quickly. This stuff basically stops your arteries furring up. So that takes time. And the longer the studies, the greater the benefits we tend to see. So there is an ongoing study called SOUL. I love that one, SOUL. But anyway, that which will give us the answer. It's another 2-3 years away. But yeah, I mean, semaglutide is a long-acting drug. So as long as they're taking enough of it, it'll be just bathing the, you know, in all the, yeah. So it'll. I can't believe it won't work.
My thoughts as well. I think it's the molecule, as Amrit said. My gut feeling is it'll be positive.
Your gut feeling. Boom.
No, another one.
I want to give a final shout out to those watching us live on Facebook. If you have any more questions, please submit them now, because we're going to round up in a minute. Do you want to talk to us about your YouTube channel, guys? No?
Yeah. Not really. But yeah, no, I'm happy to give it a bit of a plug if I'm not on mute. There we go. So yeah, we earlier this year we launched GoggleDocs YouTube channel. So www.youtube.com/GoggleDocs, where initially we started with a roundup of last year, looking forward to what we're expecting this year. We've posted some of our conference previews and highlights and reviews on there as well. But we've also picked certain topics that we think are really relevant and hot topics as well. So we've got a heart failure series on there where we've kind of worked through a case study, starting from scratch and building it up, looking at investigations, management, etc., etc. And then we're looking forward to doing a couple of more, perhaps on kidney disease, and other areas as well. And we've been fortunate enough to have some guests on as well, so some of our friends and colleagues in different areas, certain experts as well in areas of diabetes, but also beyond heart failure and whatnot. And we've been fortunate to have some very high profile kind of lead authors from trials as well. Professor John Wilding, for example, joined us for a discussion on the STEP program. And we can say it live on Facebook as well. We'd love to have the DSN Forum on there as well. That would be great. It'd be brilliant to have some of you guys, or all of you guys, on some of our videos as well. And so we're really just looking to, well, we've got a tagline, haven't we? I think Kevin's come up with a tagline. What is it?
Patrick, wasn't it?
Oh, is it me? Oh, it's that one.
It's Patrick.
Tagline. It was something like, oh, this is a very, so I think we take the data seriously, but not each other. That's
yeah, it's hopefully an informative, informal and occasionally irreverent chat about all things cardiometabolic and renal. So please do have a watch of some of our videos. We've got lots of stuff planned actually for the rest of the year. In fact, we've got a real backlog of videos to publish actually. So they'll be coming out. And as I said at the very beginning of our session, it's almost impossible, isn't it, guys, for us to keep up to film all the content, because almost every week now there's a new headline or top line or a new practice practice changing guideline published. So it's really challenging these days for us all to keep up to date. So hopefully you might find our videos helpful to maintain your CPD and keep up to date.
Yeah, we have put the link to the YouTube channel in the chat on Facebook. So if anyone wants to follow them,
and your Twitter page, we've put it all in the chat, so it should be.
Thanks for really easy for that info.
Yeah. I don't think we have any more questions. Back
as well on Twitter. We always follow you back. And if you want to be followed, we'll follow you.
So there's no more questions on Facebook, just a few people saying really thank you guys. It was really informative, excellent information. So well done, guys.
So our main action point. So the main action point is we need 3 passes for ADA next year for the 3
absolutely. of 4.
Vicky, sorry, Vicky.
Towers at the moment.
Vicky, sorry,
yeah,
Vicky.
Definitely 4.
4 passes for New Orleans.
Definitely.
So hopefully we'll see you on Bourbon Street next June.
That would be great. That would be great. Thank you, guys. See you soon.
Bye-bye.
Thank you for having us. Thanks a lot, guys. Cheers.